Good evening, everybody. Thank you for joining us. Can I just make sure that all of you who are participating have mute on and have also closed your video so that we can continue on with the event this evening. Welcome to our latest webinar in our series for health professionals. Tonight, we welcome you to join our panel as they discuss the importance and multiple applications of the basic concepts of communicable disease control and their translation into policies for the mitigation and control of COVID-19 pandemic. They'll also discuss the concepts of herd immunity, R0, a term that we've been hearing a lot about even in the public media recently, and the relevance of vaccine development, clinical trials and more. It's great to see so many joining us. We have quite a few already have joined us. My name is Maxine Whitaker, and I'm the Dean of the College of Public Health, Medical and Veterinary Sciences at James Cook University, and I'm the moderator for this evening. I'm sure some of you already know James Cook University. Maybe you've studied a Masters of Public Health or a Masters of Public Health Tropical Medicine with us. And communicable disease control is certainly a very important topic that we cover in those courses. I think for all of us, 2020 has made us more than ever aware of the importance of having some understanding of communicable disease control concepts. I would like to first acknowledge the traditional custodians of the many and various lands on which we are all living and working, and pay our deepest respects to elders past, present, future generations, and acknowledge their traditional ownership of this land. So, next slide, please. We have a great lineup tonight. For our panel, we have Dr. Diana Rojas Alvarez, who's a lecturer in communicable disease control and One Health, with us here at James Cook University in Public Health and Tropical Medicine. She's also a member of the WHO Collaborating Centre for Vector-Borne and Neglected Tropical Diseases and has a wealth of experience related to infectious disease epidemiology, outbreak investigations, surveillance and transmission dynamics of infectious diseases. Welcome, Diana. And secondly, Dr. Stephen Donohue, who is a public health physician and the director of the Townsville Public Health Unit. He has led and continues to lead the COVID-19 response in North Queensland, and I'm sure we'll have some fascinating insights and learnings from that experience to share with us all. Next slide, please. We will be opening the conversations to questions from the audience. At the bottom of your screen, you can see a Q&A icon. Please use this tool to ask any questions. I'll be moderating that and deciding when it's right time maybe to ask questions of the panelists as they present, or maybe at the end of their presentations. If you have any technical difficulties, you can let us know by using the chat button, which you can see also at the bottom of your screen. We've also received questions through the webinar registration page, which we'll also try to answer tonight if they were relevant to what we're covering. And an exciting new feature for this webinar is that we will be issuing certificates of participation for tuning into this episode. So at the end of the presentation, there'll be a QR code that you can scan with your phone and that will lead you to a form to fill out for the certificate. Alternatively, you'll be able to click on the URL link that I'll place in the chat room at the end of this presentation, and that will take you immediately to the form to complete. So enough from me. Let's start with the presentations, and please welcome Dr. Diana Rojas Alvarez.
Hello, good evening, Maxine. Thanks for inviting me to this webinar. So we are going to talk about COVID-19 and communicable disease control, and I think this is a unique time to actually talk about this topic. So let's start defining what is a communicable disease. So a communicable disease is a disease that is caused by a pathogen that can be transmitted from humans to humans, or from animals to humans, or from animals to animals. So it's communicable because it's being transmitted from one host to another. So communicable diseases had their first higher impact in developed cities in the 19th century. And thanks to a lot of development during the 20th century, like vaccines and the discovery of antibiotics, the creation of the microscope that allow us to identify pathogens, and of course, the improving in living conditions, most of the infectious disease threats have been controlled in developed settings, but they are still a public health concern in developing settings. So we have other pandemics and infectious disease threats in the previous 40 years. So let's just get back into the 1980s when HIV was a completely new virus and it just emerged. So I'm going to use this term of emerging infectious disease or an emerging pathogen and a re-emerging pathogen. What is an emerging pathogen? It's a new pathogen that hasn't been in contact with humans or with a specific population. So all the population is susceptible to infection for that specific pathogen. And that's what happened with HIV 40 years ago when it was a completely new virus. No one was able to, it took a little bit more than what it took this time to identify the virus and to give an explanation of that strange disease that now we know as AIDS or acquired immunodeficiency syndrome. Then in the 2000s, we had the emergence or the appearance of the SARS, that is the severe acute respiratory syndrome, that was very pathogenic. So that means that it caused disease, and it was also virulent, so it caused severe disease. And it didn't spread farther than China. It was contained in the spot. Then we had the reemergence that are, when we talk about reemergence of a pathogen, it's a pathogen that was controlled before, and for many reasons, the pathogen comes back and then starts being transmitted in the population again. And that's what happened with the bacteria that causes tuberculosis in the 2000s that had developed resistance to antimicrobials. Then just the last decade, we had the emergence, so the appearance and for the first time, Zika virus and chikungunya virus being transmitted in the Western Hemisphere. Those are mosquito-borne viruses, and they cause very large epidemics in Latin America and the Caribbean. And also in the 2000s, with the resurgence of the anti-vaccine movements, now we have measles back. So we have diseases that were controlled before, and now they are re-emerging, they are coming back because we are not maintaining the vaccination coverage as we are supposed to do. And then we are starting a new decade, and we have the SARS coronavirus too, that at this point, I guess, all of you have heard about it. That is the virus that causes COVID-19 or the coronavirus disease of 2019. So for controlling infectious diseases, we don't have a magic bullet that fits all. So they are usually complex diseases and they need complex strategies. So just when we have a vaccine, not even just having a vaccine or a single strategy is enough to be able to control most of these diseases. So we need different approaches to be able to control these diseases. Next slide, please. A big difference from communicable diseases and non-communicable diseases is that in communicable diseases, we have an interplay between the agent, the host, and the environment. And that interplay of all those factors are the ones who are going to give us the transmission of the different infectious diseases. Next slide. So in the agent sphere, we have different characteristics of the pathogen or the agent that is producing the infectious disease, like pathogenicity, virulence, immunogenicity, that is the capacity of the agent of generating an immune response. So some pathogens, they are able to generate like a lifelong immune response. So then once you have it, then you are protected for life. And that's what happens with many of the viruses, like chickenpox or a lot of viruses that we used to get when we were kids, but now we have vaccines. So those kind of diseases, that cause an immune response that can last for life. It's easier to get a vaccine because you get vaccinated once, and then you can get some boosters or some like new vaccination to boost again the immune response. that's completely different to other pathogens where the immune response is for a short period of time. So then you need to get vaccinated X amount period of time, like what happens with flu, or even some other diseases that the immune protection is so short that it's hard to even generate a vaccine. Then we have the antimicrobial susceptibility. So for example, some like viruses, they become resistant to the different, for example, if it's a bacteria, the antibiotic, or the virus, an antiviral, and that is going to change how that specific pathogen is transmitted. And then, well, the mode of transmission, of course, and how that pathogen is able to survive in the environment. So if, for example, that pathogen survives for a few minutes in the air, it's completely different than a spore from a bacteria that can survive for weeks in the environment. Then the host factors mostly are behavioral factors. And I guess at this point, we all know how behavior plays a very important role in the transmission of infectious diseases. So for example, traveling. So someone who travels or having like traveling often, then that might increase the risk of getting some kind of diseases. Drug use, for example, for hepatitis B and hepatitis C and HIV, sexual transmission or sexual behaviors, then are going to allow the people in this case to be more at risk of getting a specific pathogen, smoking, alcohol, and just having different contact with people. And I guess Stephen is going to talk a little bit more about his experience with contact tracing and why is it so important for COVID-19. Also, age plays a very important role in this interplay between this, the agent, the environment, and the host. So for COVID-19, for example, we know that there are specific age groups that are more at risk of developing disease given infection. And also for some diseases, there is a gender gap where one gender is more affected than the other. And then we have the environment when we have the climate. So for example, in areas where there is the presence of a mosquito, then in those areas is where people are going to get those kind of diseases. If you don't have the mosquito, then you are not going to get a vector-borne disease. Then the sanitation conditions, overcrowding, the social and political environment in a specific country, or now that we are in a pandemic, the global social and political issues are playing a very important role in the transmission of an infectious disease. And of course, the healthcare system, because the access that someone can have to a healthcare system is going to give that person access to diagnosis, treatment, a follow-up, and maybe preventing some severe manifestations of the disease.
So Diana, can I just interject there? Would it be when people talk about people maybe with diabetes or immune compromised, they are host factors that also affect this interplay?
Yes. So those are examples of host factors. So these comorbidities or pre-existing conditions are host factors that are going to play a very important role in this interplay, because it's not the same. Like you can have two people exactly from the same age, but if one person has a comorbidity like diabetes, it can have a completely different outcome in being infected with exactly the same virus. So yes, those are host factors. Next slide, please. Then we have different kinds of pathogens like bacteria, viruses, parasites. And well, as I mentioned before, we have the pathogens have different characteristics. So one is infectivity, that is the capacity of a pathogen to be transmitted or infect different types of different hosts. The other one is pathogenicity, that is the capacity of a pathogen to generate disease given that that person is infected. And then the virulence is the capacity of that specific pathogen to generate severe disease or deaths. And a common way of measuring the virulence of a pathogen is with the case fatality rate. So I guess you have heard a lot at this point about the case fatality rate of COVID-19 and how it had changed since January when the transmission started, once the pandemic was declared, and once we started collecting more data. This is a number that had changed, and we have estimations of case fatality rates in different countries that are sometimes it just exceeds 10 times more if you compare, for example, the case fatality rate of Italy with the case fatality rate of Germany. And the main difference is that it's heavily influenced in how many mild cases are not diagnosed. So that's why one of the policies of COVID-19 is test, test, test. Because the more we test, the more mild cases and asymptomatic cases we might be detecting, and then we will know a little bit more about the case fatality rate, of course, but then also to be able to do all the activities related with control, that is isolation, and then follow up and contact the contacts. So also I'm going to define what a susceptible person is. So a susceptible person for a specific pathogen is an individual who hasn't been in contact with that pathogen before. And so that makes that person susceptible if it's, for example, a viral infection, or we are all susceptible once the immune system is not able to respond and control effectively that specific infection. And then three other concepts that have been interchanged and used a lot during this pandemic are eradication, elimination, and control. So a lot of countries that are aiming to eliminate the transmission of the virus in their jurisdiction, then they have mentioned that they are aiming for eradication. Well, eradication is a complete and permanent worldwide reduction almost to 0 cases. So to be able to eradicate COVID-19 or the SARS coronavirus too, we will need to control it all over the world. So we just have one disease that we have been able to eradicate, and it was eradicated with the help and the intervention and a lot of effort with vaccination, and it was smallpox. Other than that, we are trying to eliminate other diseases, but talking about eradication of COVID-19 or SARS coronavirus 2, when we are in the middle of a pandemic and hundreds of thousands of cases have been reported every day, that's a bit unrealistic. We can definitely aim for elimination. And that is what Australia has been doing. With all the interventions, we are aiming for elimination. That is the reduction to 0 or very low rate of new cases. And they are just in a defined geographic area. So that's what we can aim. And there are some other settings when the transmission, the community transmission is so widespread that aiming for elimination without a vaccine or without a very effective intervention is going to be more complicated. So some countries, for example, in the Americas, they might be aiming for control. So that's reducing transmission, reducing morbidity and severe cases. Next slide, please. Then other two concepts that are very important to understand what is happening with infectious diseases is the difference between infection and disease. So once someone is exposed to a different pathogen, they are going to be infected by that pathogen, but some people will never develop symptoms. So people can be infected, infectious, so that they are able to transmit the pathogen to a different individual, but they are not showing symptoms. And I think that is one of the secret weapons of the COVID-19, is that it's able to have a large proportion of asymptomatic people. So that makes it more likely to be contagious. And
so, sorry, Diana, that was one of the questions one of our participants asked, what makes it so contagious and virulent? So that's the answer to that, is it?
Yes, I will say that when that is a very good characteristic of a pathogen, if it wants to be transmitted and sustain transmission, is to have a large proportion of asymptomatic infections. Because it's completely different if someone, for example, is infected with Ebola, that they get infected and they get very sick. So people stay home and they are not going to be in contact with a lot of people. So that's a kind of the disease that is easier to control. But when you have people that are getting infected and then they are completely asymptomatic or the infection is very mild and they have to travel, they are going to pack their bags and they are going to get into a plane. So that makes a pathogen more likely to cause a pandemic, like what is happening with SARS coronavirus too. And then we have the other dynamic, that is the dynamics of disease. That is the people who are infected and develop symptoms. So then for that, we have the infection, then we have an incubation period. That is the time between infection and the date of onset of symptoms. And what we didn't know 6 months ago, but we know now, is that some people in the incubation period, even if they don't have symptoms, they can be infectious. And that also creates a problem when you try to control a virus like the SARS coronavirus too. So all these key concepts are very important for you to understand why all the activities that have been done worldwide to try to prevent the spread, because they act like you are infected, wear masks if there is community transmission around you, is because of this, because you don't know if you are infected and you are not going to develop symptoms, and then you might be exposing other people. Next slide, please. Then there are different modes of transmission. So we have infections where you have direct transmission, like sexually transmitted infections, where you have direct contact with the other individual, or like rabies, that you need the dog or the animal to bite the individual to get infected. And then we have pathogens that have an indirect mode of transmission. So for example, the droplet transmission with short distances, or the droplet transmission in long distances. So when people are coughing or are sneezing, or even the airborne transmission, that is when very small droplets are produced and then they stay in the air. Well, we have more definitions. There are epidemic, pandemic, and endemic. So an epidemic is usually when there is an unusual increase of number of cases. That is what we are seeing here in this epidemic curve, that you have an increased number of cases and then they go down. But usually the epidemic is limited in time. So it has a beginning and usually has an end, and is limited also in space. Then we have a pandemic, where we have the start of the pandemic, then it's going to be a peak and it's going down. So it is limited in time, but it's unlimited in space, it's worldwide. And then we have the endemic transmission, where there is sustained transmission of the pathogen. And it's usually, so it's not limited in time, but it might be limited in space. So it's endemic in some settings, but not all over. Then the beauty of infectious diseases, and that's why I love infectious diseases, is that they are very predictable. So once you know the pattern and once you know the different parameters, you can model that. Once you know the 3 basic epidemiological questions that are who, when, and where. So who gets infected, by whom, at what rates, and where they are getting infected and when they get infected, then you can model those parameters, and then you can understand what is happening. And then we have a concept that is key for infectious diseases. That is the basic reproductive number. That is the average number of people that an infected person can infect in a completely susceptible population. So to have an epidemic, we need to have an R0 that is larger than 1. So at least one infected person is able to infect one more. So if that condition is not met, there is not going to be an epidemic, right? So we have pathogens with R0s of 13, for example, measles. So if one person is infected and gets into a susceptible population, one kid is able to infect 13 more kids. That's why we had these large outbreaks before the vaccine was discovered. And then we have an epidemic peak. The epidemic keeps growing. And then once it reaches a point when there is an equilibrium between the susceptible population and the people who had already been infected, that's when the epidemics start decreasing, and that's when the R0 goes lower than 1. And that's what we aim with vaccination. Next slide. So there are 2 things that are going to affect the speed of an outbreak or an epidemic. One is the number of individuals that can be infected by each infectious case, and that is the R naught. So if, for example, with a pathogen, one person can infect 2 or can infect 3 people, that's why that number is so important. And also the time that it takes between a case is infected and when they are able to infect other people. So if we have, for example, with the flu, the incubation period is very short. So it's about 2 to 4 days. So then the number of infectious individuals is not that large, it's about 2 or 3. But the incubation period is very short. So we have these very large outbreaks in a very short period of time. With COVID-19, at the beginning, we didn't know which was the incubation period, but now we know that the mean incubation period is about from 5 to 7 days, but it can go up to 14 days. And that's why we talk about isolation and quarantining for at least 14 days. Next slide. Then we have another concept about the critical vaccination fraction. And this is key because a lot of people have talked about herd immunity. So when we need to vaccinate a large enough fraction of the population to make the R naught less than 1. So for example, to get herd immunity, for example, in the case of COVID-19, where the R naught is around 3, so the proportion of the population that we will need to vaccinate or get infected, if we are going to talk about herd immunity due to natural infection, is going to be usually 1 minus 1 divided the R naught. So if the R naught is 3, then the population that needs to be exposed or have been infected to be able to have herd immunity will be around 66%. And that's where the 66% number comes from that formula there. So getting to 66% of the population infected worldwide with a new virus, because it feels like it's been around for a lot of time, but it's been 6 months, right? So we are 7 billion people. So to get to 66% of 7 billion people is going to take longer. That's why it's where we are aiming, and there are more than 140 vaccines in development, because getting to herd immunity is not going to be an easy task. Then we have the different responses to infection. So active immunity is when someone is exposed to a different pathogen. So they get immunity due to that infection, or for vaccination, we can get active immunity due to vaccination. Passive immunity is the one that gets the newborns from the mother. And then herd immunity is an indirect immunity that the population confers to susceptible population or individuals.
So Diana, can I just ask a question there? And then also, we're running a little bit out of time, so I might then ask you to go to your last slide. But somebody's just asked, could you calculate an R naught for a specific area rather than for the whole country? Could you work out what an R naught is, say, for Melbourne? Is that something that's possible?
Yes, it's possible, because actually the R naught is not a magic number that is from all the places, because they are setting specific and they are population specific. So yes, and usually the R naught is estimated with the epidemic curve. So when we use models to estimate the R naughts, so with just seeing how fast the epidemic curve is increasing, we can estimate the R naught. And yes, they can be estimated setting specific. And also you can follow the R naught along the epidemic.
Okay, thank you. So we might, if we have time, we could come back to the slides, but maybe we just go to your last slide about the steps for investigation, because it leads nicely. We might be able to come back to these. Yeah, thank you.
Okay. So based on all these CDC concepts, we have 10 steps that I'm going to go through very briefly, but Stephen is going to show how all these 10 steps will apply into the COVID-19 understanding and also control. So, the first step is to prepare to investigate. So once we hear that there is an outbreak going on, we have to get ready to investigate that outbreak. Very important to verify the diagnosis. So at the beginning, the diagnosis is very blurry. We don't know what it is. We have a syndrome, but we don't know what it is. And then confirm the existence of an outbreak. Constructing a working case definition that might change along the time. Find cases systematically and record the information, because the more cases we have and the more information we get, the more are we going to understand about this disease. Perform descriptive epidemiology, as I mentioned before, who is getting infected, where they are getting infected, and when they are getting infected. Generate hypotheses to address the problem. And then once you are getting more data, we can reevaluate. That's what science is about. So we know more today than we knew 6 months ago. So it's okay to say we have more data, we know more, let's change the strategy or the intervention. Then compare with the lab and environmental studies. Of course, implement control and preventive measures, maintain epidemiological surveillance, and always communicate findings. That I find that very interesting during this pandemic. We are getting daily data and communicating findings and updates.
Thank you very much, Diana. That was a fantastic overview of what often takes a few hours to get through. And thank you, you've put it into a very compact presentation for us. And we will come back to ask you some more questions at the end of all of the presentations. Stephen, I'd like to call upon you now to present your real life, the grounded approach to doing these 10 steps of outbreak investigation. I also would like to hear, particularly later, how this re-evaluating of the hypotheses sounds very good scientifically, but has been a nightmare to have the media and general public and politicians understand why you don't seem to know what you're doing. Thanks, Stephen.
Thank you, Maxine, and thank you, Diane. So let's go to the next slide. Yeah, so it really did feel like building the plane while we're flying it. And of course, humans are very vulnerable to respiratory viruses, and we've known that for years, and they can go around the world very quickly in an aeroplane. So not only was it a completely new respiratory infection, but I think we knew pretty quickly that it was spreading easily between humans, and everyone seemed to be susceptible. So from quite early on, I think a lot of us realized this was going to be a pandemic virus. But the only real way of finding out, what those parameters are in terms of infectious period, incubation period, how sick people get, was to do large case series. And I guess the issue for Australia is that we've never had quite that many cases to do the big series, and we've had to rely on information from other countries, including China, to get those parameters and hope that they were the same where we're working. So it became pretty clear, whenever you see all age groups of the population getting sick with an infectious disease, you say, well, that population hasn't seen this before. And yeah, it still appears as if all humans are susceptible, although children tend to do very well. A lot of the speculation is that this generation is copying it for the first time at an older age, and that's why older people are getting sick. So the vulnerable groups, what health conditions make it more likely for people to get complications, respiratory distress syndrome or die, that's become more clear. A lot of work, of course, in terms of diagnostics. The big difference between polymerase chain reaction and serology is the PCR is actually detecting the DNA, the RNA of the virus itself, which is the signature when the virus is present, whereas serology is the antibody reaction of your body, and that's always going to be delayed by about a week or two, and is not nearly as reliable in picking up recent or acute infections. So a huge amount of work, of course, lots of testing, lots of interviewing, lots of trying to track people to find out where the cases are. And because public health is not all that well resourced anywhere, the idea that you can just train up a few people to do contact tracing at the spur of the moment has been a difficulty everywhere, because these are highly experienced and well-trained people. It's very difficult to get that kind of staff. And of course, we were going to need staff for all sorts of other things, including potentially overwhelming the hospitals. So a lot of work went into preparing for what could be a tidal wave of infection, getting enough beds, protective equipment, ventilators, oxygen, and all sorts of studies at a record pace, trying to find something that could treat or something that could induce immunity. I suppose you don't want to ask the question, how many people have to die before we get to herd immunity? Next slide.
Oh, so could I just
Yeah.
interrupt there, Stephen? Sorry, if we could go back. I have got a question here. How much testing is actually happening in Townsville, seeing you're working in Townsville?
Yes, very good question, Maxine. So we're getting close to a couple of hundred tests a day in Townsville. I think it's a bit more in Cairns because it's a tourist town. The health department is asking us to double that. And so lots and lots of effort trying to encourage people, even with a sniffle, to come forward. One of the big problems, of course, is it's very hard to distinguish this virus from any other flu, cough or cold. And that's become one of the big problems in terms of finding cases and controlling the disease. So yeah, the authorities have made it very clear, even if you're worried and you don't really have symptoms, come forward and we'll test you. And that's been one of the strengths of the response in Australia. Okay, let's move on. So we do know, as I said, it's really hard to tell just from the symptoms whether this is coronavirus or not. And so we had to do testing initially based on risk. For example, people who had a severe disease and or travelled in from overseas or were part of a known cluster. And we had a real shortage of testing materials early on. But then later on, that came unstuck, and we've had to basically try to test everybody who has any kind of related symptoms, respiratory symptoms, fever, and a whole broad range of other things, nausea, vomiting, weakness, joint pains, all of them could signal coronavirus. So again, the old-fashioned infection control and public health measures, we know they work. If you can find the cases, isolate them, keep them away from other people while they thought to be infectious, then that can really slow down the spread of the disease and help to bring it under control. And of course, with finding all of those cases, it's really important to trace their contacts, who they've been close to, and I'll come back to that. We know that the standard things in terms of preventing respiratory diseases, what your mother would have told you, don't cough on other people, wash your bloody hands, do some cleaning because these droplets can fall on surfaces and then you can touch your face, using protective equipment when you're close to somebody who's sick in particular. And of course, then we had to bring in some things when not all of those things worked to an extent, but they were not working enough. And so quarantine, which hadn't been used for a generation in Australia, had to be brought in. Closing borders, who would have thought that we would go to those extremes, and then locking down various parts of the economy just to reduce the mixing of the population and people getting close to each other. Has been really, really tough because this is a very easily transmissible infection. So social distancing, restrictions on events and transport. Some of the rules are seen by the public as arbitrary. And I've put a picture there of a couple of people on a beach. How on earth do you get a respiratory virus on a beach in the sun? But in fact, the rules are often about what's indirectly related to that event. So when you go to the beach, you meet with your friends, you go out for coffee, you're getting out of the house. And so they had to restrict things that they could do, even though the people didn't necessarily understand the rules. And that's one of the problems that we're running into now. If people don't understand the rules, then they're not necessarily going to keep up following it. So that's why we have to keep communicating about what's important and what's less important in the way this disease transmits. So yeah, we can't shut down the whole economy all of the time. And that's why we're in a bit of a pickle in Australia, because we've got that balancing act between trying to suppress the disease and shut everything down. Next slide.
Stephen, we've just got a person asking, why aren't you testing all the people who are coming off the planes from New South Wales and Victoria? And I know you're one of the people who goes out to meet those planes. Is it just this sheer number of staff, or epidemiologically does it not make that much sense either?
It's a bit of both, Maxine. Of course, not everybody in New South Wales has got the disease. The prevalence is still tiny. And we also know that you can test people negative on the day they fly in, and then a week later they can still get coronavirus. They may be at the beginning of the incubation period, and then we just don't have a test to find people in the incubation period. It's a bit like checking the post box before the postie's been down the street. It doesn't work. So we don't have a test immediately after someone's been exposed to the virus that can exclude them. We would have to follow them up and do the quarantine anyway. So we have to be a bit more clever about how we direct our testing. So this is just a picture of the process of contact tracing and quarantine. Very quickly, if we can find a case, we talk to them. We make a long list of everybody they've been close to in terms of who might have given it to them and who they may have given it to during the period where we think they're infectious. And as Diana said, we now know that some people can be infectious before they get symptoms or have so few symptoms that they don't even report being ill. So all of those potential contacts, we have to trace them. Those who've had a very trivial interaction, like you walk past them on the street or you bought something at the supermarket from the checkout, very few of those get sick, and they can be just given some education about what to look for. But the close contacts, they've been face-to-face, they've been a long period, more than about 15 minutes close together, same household, more than 2 hours in the same room, then you've got a pretty good chance of getting the infection, provided the case was infectious at the time. And of those, you have to divide them again into those who get sick or are sick already, and they're suspected cases who must be immediately isolated and tested, versus the contacts who are well. They may not ever get coronavirus. Most of them don't, but you've got a whole lot of people that you need to keep away from other people in case they become infectious. And we use 14 days because that's the maximum wait incubation period, average about 6-7 days. And so for 14 days, you can be pretty sure that they would have got their disease by then. And so there is a difference between isolation, which is for sick people, and quarantine, which is a waiting period for people that are well. All right, next slide. So quarantine is something that really we haven't seen in our generation since the days of cholera and yellow fever. It's really, as I said, it's a way of separating people who may get the disease, and therefore we can get a head start on trying to keep them away from others. And then if they're sick, we isolate them and test them. We've done that mainly with close contacts, but more recently international and even travellers interstate or from hotspots within Australia, trying to get control over the transmission of this disease. So there has been some confusion. I think a lot of commentators and politicians have used isolation and quarantine interchangeably, which is a bit unhelpful because people in quarantine are generally not infectious and there's fewer precautions required. So all sorts of problems about where to put people in quarantine, what are the systems to support them and monitor them? Are we going to force people into quarantine? The downside of that, of course, is that then they run away and they deny that they're contacts if they think they're going to be imprisoned. And so we have to look at whether or not people pay, what are the costs, what are the pros and cons, encouraging people to cooperate and provide us with information. And of course, sometimes if people get out of quarantine, as happened in Victoria, or their breakdowns in infection control, that can be the trigger for further transmission in the community. Although I think in Victoria, they've just released so many restrictions so quickly that those initial outbreaks were able to magnify and continue. So it wasn't just a breakdown in quarantine. Okay, next slide. So look, there are lots of debates, as you mentioned, Maxine, conspiracy theories, you know, that it's the, what is it, the 5G radio waves that are spreading the virus, blaming different nationalities or countries, conspiracy theories. One of the problems I think we've had as we've scrambled to try and get reliable information is what I call a novelty bias. So we know pretty well that this is a pretty ordinary respiratory virus. We know most of the spread is through droplets and to households and close contacts. But the reports that get magnified in the press tend to be the exceptions, where the virus has lasted longer or spread further or done something unusual. That doesn't mean that it's the normal way that it works. This thing doesn't have an R0 of 13 like measles, as Diana was talking about. It had an R0 of maybe 2.5. So we think we understand it pretty well, and it's not to say that sometimes there are not super spreaders or airborne transmission, but it's not the majority, and we certainly would never have controlled it in most parts of Australia if it had been that remarkable an infection. All right, so I guess one of the other confusions is the idea that if you're a contact, then you're automatically infectious, and then people worry about contacts of contacts. So I tell people there's just no such thing as a contact of a contact unless and until the first one becomes infectious and sick. So airborne transmission, we're not denying it, but we don't think it's the main route of transmission. Otherwise, it wouldn't be spreading just within families, for example.
So I had a question about that too,
Yeah.
Stephen, because many of us have seen in the press recently, particularly the scientific literature around, is it airborne or aerosol droplet, and what that means to things. WHO is still, its experts are still trying to look at the evidence. What do you think we're doing here in Australia and Queensland around that debate?
So look, I think it's unhelpful to deny that it occurs. There are a few well-described incidents that were unusual, and it is quite easy to generate aerosols with this virus in them that float in the air for long distances, the very tiny droplets that spread in the air. But having said that, we know that the way the virus transmits epidemiologically doesn't fit having a major element from airborne transmission. So at the end of the day, even though theoretically it's possible and we can produce that type of droplet, what we're seeing in the real world doesn't add up to the same picture as measles. And that's what I talk about. We know that we can control it by looking at the majority of the infectiousness. And masks is another really good example. They do help, but they help most on the sick person and in environments where there's a lot of virus and where it's hard to keep away from other people. So in Queensland, there hasn't been much call for it so far outside of health services. And of course, we were short of protective equipment for a long time. But I can see that it may come back if we have another wave. All right. Look, one of the problems that I have with this is that we really need to do better to talk to the community and explain all of this. Having a single spokesperson for the whole country or the whole state cannot do that. And so there's been a problem in terms of the health promotion, the social sciences, the communications. I don't think have been ideal in explaining these restrictions and how to protect yourself to the public. And if they don't understand it, then they can't maintain it. So that's the issue there. So I guess the problem in Australia has been that the first wave has largely been about imported infections, which were easy to identify and quarantine. The second wave we're seeing in Victoria is locally acquired transmission with no known contacts in the community, and that's much more difficult. And if you don't have some controls over particularly industries where they're deliberately mixing people at close quarters in noisy, dark environments indoors where people are drunk, then you're going to have a problem. So I guess we're going to learn those lessons. Next slide.
And we might need to pop quickly through a few of these to get to your learning the lessons. Thanks, Steve.
All right, so this was, again, we'll just skip through some of the stuff about models. We've got some amazing models, but you've got to remember that they're only as good as the information that goes into them and only answer the questions that we ask. A lot of the things that actually happen in the real world are political decisions, and you really can't model for that very well. So in Australia, we went hard, we went early. We've achieved control in most of the country, but not all. And I guess the key problem is that it's a very unstable and difficult situation to try and tolerate a little bit of coronavirus because it can spread and multiply so quickly. Next slide. Yeah, so the economics is difficult. We know this virus is not going away. We're not going to eradicate it from the earth. HIV, as Diana mentioned, led to permanent changes in the way we do infection control for bloodborne virus. I think this is going to lead to permanent changes in people's personal bubble and the way they think about respiratory infections. We're going to have to look at all sorts of entertainment and whether or not it's a good idea to have that amount of mixing and that amount of travel until we get much better control or treatment or vaccines. So a lot of this is being driven economically rather than scientifically, and that worries me because we're trying to balance people's livelihoods versus a mortality rate, and nobody really has the answers to those questions. So what are the rules that we need to apply? Can we be better at this? Can we explain this better and still have at least most of the economy working? So we've had a temporary suppression in places like North Queensland, but that I don't think can last if we remove all of those restrictions that have helped us to get the degree of control we need. Next one. So last slide for me, we need to prepare for outbreaks. Public health training and capability is always important. Australia has learned the lesson that you've got to manufacture drugs and equipment and protective gear in your own country just for this kind of problem. We know that ordinary infection control and standard advice does work for this disease. It just needs to be very, very thorough. And you need multiple layers of protection. You can't just pick and choose between the public health and community interventions. My advice is not to wait for a vaccine, not to wait for drugs. It could still be years, if ever, that we get those things. We do know what to do to slow this down so our hospitals are not overwhelmed. At least if it goes through very slowly, we won't get so many deaths in a well-off country like Australia. So changing people's behaviour is hard. We need to put all of the supports in and all of the information in to help people to do that. We need to get our terminology and messaging right. But at the end of the day, there are economic decisions that we have to live with. Thank you.
Thank you very much, Stephen. That was fantastic. And again, thank you for having the time to be able to join us, because I know it has been an extremely busy time for you. Just on that one around terminology, just one of the questions that's come up is, would you actually call it a second wave in Victoria when it was never actually cleared? Doesn't a second wave have to be that there's no new cases for a while and then it reappears? Or is this just a spike?
Yeah, the really good question, Maxine. And look, I don't think there's any definite terminology, Diana, is there? Locally, you can say that was a wave due to mainly imports and that we think that we had local elimination, but we're not sure. And now in Victoria, things have risen again. So I'm quite loose about that particular terminology. We do know that all epidemic curves are averages over different curves in different areas. And that's, again, what we're seeing here.
Okay, thank you. So a couple of other questions. I've had quite a few before the seminar and now asking about the immunity question. So around, well, if there's no evidence at the moment of lasting immunity post-infection, why would, particularly say the Swedish model, why did they think that herd immunity would be protective? Does it also mean a vaccine is really not going to be a solution for us? Do either of you want to comment on that whole area about how much immunity does it look like we've got? Yeah.
Maybe if I could start, Diana. People don't get better unless their immune system helps them. So there must be at least short-term immunity. But we know from the other coronaviruses that cause common colds that sometimes the antibodies in particular wear off and your cell-mediated immunity may not be enough permanently to stop you getting it a second time. But my own belief is that because this is a new virus, it's older people who are suffering. I think the next generation who had a dose of this virus as children, they may not get so sick the next time. So of course, we haven't had the virus long enough to know. We're still looking at the different markers, including antibody, but my guess is it will be partial. What do you think, Diana?
Yes, I completely agree with you, because what we know about other coronavirus is that they create a very short-term immunity. So we should not expect from this coronavirus that it's going to create a long-term immunity. So with the development of a vaccine, we might get into the challenge that people will need boosters every year, like what happens with flu, or it needs to be a boost every X amount of time, because we don't know how long the immunity lasts. But even with a vaccine, we might still have circulation of the SARS coronavirus to and COVID-19 cases for a while.
Thank you.
And Maxine, I'm not sure we can call Sweden a model. I mean, you've got to answer the question, how many dead people do you want before you reach herd immunity without a vaccine? It's a very big number.
But also I did read that there's only, maybe about 25% of people who are showing some immunity. Even with that level of exposure, they still didn't get the levels of immunity that they thought they would. But yes, they got the highest death rate in Europe. Stephen, the other thing you talked about, some of the changes we've had to put in. One of our commentators has asked or commented, there seems to have been some very quick changes to the Public Health Act that to some may seem very draconian. How long are these going to stay? Are they going to be reversed when we don't need them anymore? Or was this a chance for some tightening of rule acts that are going to be hard for us to release later?
Yes, that's amazing. A lot of people don't know that public health legislation the world over is some of the most extreme powers. Arbitrary arrest and detention. When lives are at stake, then even democratic governments have no hesitation in suspending the normal way of doing things. And so those powers have been in the Public Health Act for a long time, and they've just been exercising them with emergency powers and declarations and whatever. Those things will be wound back as soon as it's possible. And yes, we do have to keep an eye on human rights and make sure that this is proportional. But I think at the moment we're getting the balance not too bad in Australia, considering that we're doing pretty well.
Well, thank you very much.
I have a comment.
I do have to wrap up. We're getting very close. Go ahead.
So, I hope some of these interventions stay in the population. So, for example, washing hands now became a fashion, and we should always wash hands. So washing hands is such an easy intervention that is going to prevent diarrhea, can prevent respiratory infections, can prevent so many infectious diseases, that if we keep that one, you will have a very long-term effect in the population. So I hope some of these activities that we are doing now are going to stay forever, even if they are not mandatory. Washing hands, we should all wash hands. And if we are sick, we should stay home so we don't infect other people.
Yes, thank you. I think it wasn't so much the behaviour change that the commentator was talking about, but things that were actually legislated and mandated. And so finding that balance, and as you said, trying to get that behaviour change to sustain is going to be very, very important. Look, if people could clap, I'm sure they'd give you a big round of applause. I know people are saying, that this has been fantastic overview for them. So we could continue this all night. All of the questions you've put up or you gave beforehand, we share them with the two panelists so that they could answer them afterwards if they weren't talked about here. Again, I'd like to thank both Stephen and Deanna for their time and their expertise. So thank you very much. Make sure to join on the 28th of July for our next webinar for health professionals. It's going to be about the animal-human health link, where we'll be providing an overview of the complex relationships between people, animals and the environment, and how they impact on health. And obviously, again, very linked to what we've discussed today and very linked to the pandemic in which we are all part of right now. So thank you, everybody, and I look forward to seeing you next week.
Thank you.
Thank you.
Thank you. Bye, everyone.